Good evening, students. Welcome to you from Sri Rama Hospital, Jagapet. The hypovolemic shock. We have studied about the etiology, the pathogenesis. Okay, the students, now let us continue the topic on the remaining part of the hypovolemic shock. Just I will summarize what I have said in the previous class. Still are able to, or are not able to see the video? I think now now it is corrected. Okay. Manavya, what about you? Okay, that's fine. So the summary of what I told you in the previous class is reduced circulatory volume is the cause of the shock. So irrespective of the type of reduction, it can be the blood, it can be only RBC, plasma, or only fluids, whatever it is. If the volume has decreased, then that leads to the shock. So the main feature, what body does is redistribution of fluid. How this redistribution is done? What is the mechanism for redistribution of fluid? Yes, that's good. It is peripheral and splanchnic vasoconstriction. Not only peripheral but also splanchnic. The sequelae of shock are due to compromised tissue perfusion of certain organs. The complications of shock are dependent upon the duration and degree of shock. Longer the duration without treatment, the greater the complications. Clinically, shock is evident only upon reduction of blood volume by 500 to 750 ml. Now let's go to the discussion of the management of shock. Principles of management to prevent further blood loss. It is a hypovolemic shock. The hypovolemic shock most commonly is due to hemorrhage. So the first principle of management is to prevent further blood loss, to restore blood volume, to manage sequelae and complications of hypovolemia. We have seen a lot of sequelae and complications. Those should be managed. The urgency of management demands concurrent efforts in diagnosis and treatment. That means usually in many of the other cases, what you do is once the patient comes, you ask the patient to lie down, examine the general condition, take the detailed history, then do the local examination, arrive at a reasonable diagnosis that is called the provisional diagnosis. Then you go for investigations, confirm the diagnosis, then you proceed with the treatment. But here it is not like that. As the patient is being received, you diagnose shock, or just to take off minute time to say the patient is in shock. So, for example, a patient is brought to the casualty and you are there as a casualty medical officer. I said, it is a case of shock. How can you say whether it's shock or not? What should be there to say that patient is in shock? A quick decision you must take. Yes, whenever a patient is brought to you in a state where he is anxious, sweating, peripheries are cold, pulse is rapid, blood pressure is low, or pulse volume is low. So that is when you make a diagnosis of shock. So just it takes only hardly few seconds for you to make this diagnosis, especially in shock. Next, what are the two main causes? Hypovolemic shock, central shock. And if the patient has an history of infection, it is septic shock. So there are only mainly three things. Then, of course, the other things by history itself, you will be able to say the distributive shock, the obstructive shock, etc. So once the patient is being received and with a short history, you must come to a reasonable diagnosis of the type of shock. So as you are diagnosing, you have to prepare yourself for treatment also. So diagnosis and treatment should go concurrently. So you will be asking the patient how this happened, since how long it is there, and you will be requesting the nurse to get you the IV fluids, the IV cannula, oxygen cylinder, etc., ready. So this is all done simultaneously. So it is a concurrent effort in the diagnosis and treatment. Priority is given to the maintenance of vital organ function because body is doing this. So you also copy the body's intelligence. So the management is resuscitation, diagnosis of hemorrhage. So once the patient is received on the table, immediately you must start resuscitating him. He is in shock. So that diagnosis is sufficient. You start him the resuscitation measures. Then you go and examine the diagnosis of the hemorrhage, where the hemorrhage come in. Is it external hemorrhage, internal hemorrhage, or internal-external hemorrhage? How much blood is being lost? Since how long he is bleeding? Still he is bleeding or stopped bleeding? So those things you have to take into account. Then control of hemorrhage. First, immediately you do certain first aid measures to control the bleeding. Then you do appropriate surgical procedures to control the bleeding. Then restore the blood volume. So you must calculate by the patient's history as well as the clinical parameters how much blood the patient has lost, and you must restore the blood volume. So resuscitation, circulatory access, and IV fluid or blood administration. So this is the resuscitation in shock. So in hemorrhage, it should be placed, precede the other measures. So ABCD, that means airway, breathing, circulation, drugs and disposal. So this is ABCD of resuscitation. Airway. If the patient has any injury to the airway, then you must first attend the airway. Otherwise, the patient has come to you with just history of hemorrhage and shock. Your first priority is to the C, not to the A and B, to the C, circulatory access. Then after that means you get IV access and IV fluid, airway patency, breathing assistance, and bleeding control by first aid methods. Then diagnosis of hemorrhage. So ABCD is altered here. You can see here. ABC is here. Lastly comes the diagnosis of hemorrhage. The bleeding control by first aid procedures and blood and fluid administration should go concurrently. So the statement is being repeatedly to you. So whenever the patient comes to you with hemorrhage, you must take the history, give the first aid, start IV fluids. External hemorrhage is obvious. If there is a wound is there, you can simply see the bleeding from the wound or hematoma there. Concealed hemorrhage is diagnosed in case of shock without any evident external hemorrhage. So, for example, the patient has internal bleeding. There is a rupture of aneurysm of the liver. So, there is bleeding into the peritoneal cavity. It is not seen outside. But you made a diagnosis of shock by the clinical parameters. The patient is becoming paler. That means he is losing blood. So, then you will check where the bleeding is occurring inside. Clinical examination of the cavities, abdomen, chest, and by imagiology, X-ray chest, abdomen, ultrasound scan, CT scan, diagnostic peritoneal lavage. So these investigations you do. I will tell just one example. In the earlier part of my surgical career, I worked in Singareni colleges. One night, a patient was brought to me. So the history was he was playing cards around 8 o'clock in the night, and while playing the cards, he fainted and he vomited twice. So immediately he was brought to the hospital. I attended on him. So when I saw him, the pulse rate was about 116 per minute. Blood pressure was only 80 millimeters of mercury pressure. He was profusely sweating. The palms and feet are very cold and they are moist, and patient was restless. Then those days the pulse oximeter etc. was not there. So our parameters that was available with us only is the blood pressure sphygmomanometer. So I recorded the pulse rate, blood pressure. Then I diagnosed it. Probably it is a shock. He was an elderly man. He was around some 65 or 70 years old. So it could be myocardial infarction or it could be a hemorrhagic shock. There was no external hemorrhage. So that's why just I made him to lie down on the bed, and then I opened his shirt and examined the chest as well as abdomen. So when I was examining the abdomen was seen bloating. He is paler. So whenever pallor is there, that indicates that there is some loss of blood. So then when I did immediately what I did was I have put a needle into the abdominal cavity, aspirated. Frank blood was aspirated. So what does it mean? That means there is bleeding into the peritoneal cavity. So he was having internal hemorrhage. So that was my diagnosis. Of course, immediately fluids were given, then blood was transfused, And of course, whenever there is bleeding into the peritoneal cavity, you must operate upon. So he was operated. And of course, later it was found to be he was having a bleeding hepatocellular carcinoma. So that was the diagnosis. Okay. So just I want to tell you here is whenever a patient with shock comes, there need not be always external hemorrhage. If hemorrhage is not seen, it can be due to myocardial infarction or the shock can be due to internal hemorrhage. The internal hemorrhage can be usually into the cavities, chest or abdomen. So by clinical examination of the cavities or by imaging studies like X-ray chest and abdomen, ultrasound scan, CT scan, diagnostic peritoneal lavage. These will be able to detect the lesion in more than 95 or 99% of the cases. Control of hemorrhage. So I will tell you about the resuscitation after finishing the control of hemorrhage. First, I will tell you about the control of hemorrhage. First aid. Of course, the priority is different. I told you. You must give IV fluids and then start IV fluids and then necessary blood transfusion has to be given. So what is the fluids you have to give, how much blood you have to give, all that I will discuss after I tell you about how you control the hemorrhage. The clinical examination of cavities is just routine test, inspection, palpation, percussion, auscultation. That's all. If, for example, if there is bleeding into the chest cavity, you will get the signs of pleural effusion or you will get signs of hydropneumothorax. If there is fluid in the peritoneal cavity or blood in the peritoneal cavity, it always causes irritation of the peritoneal cavity, producing pain, tenderness, spasm, or guarding, and shifting dullness. You will find shifting dullness. So, with these clinical findings, if the abdominal distension also is present, then you will suspect there is bleeding into the abdominal cavity. It may be into the gut, it may be into the peritoneal cavity, it may be into the retroperitoneum, it may be into the pelvis. So you have to search all those spaces. Okay. Then control of hemorrhage, first aid measures, operative measures. Operative measures is by surgery, endoscopy, and by therapeutic embolization. First aid, pressure and packing. If there is an external wound is there, so immediately you must apply pressure and pack the wound. So you take a pad, that means in the dressings you will be seeing pads. So the dressing pad, you take it, keep it over the wound, and then tightly apply bandage or tightly hold it. So the bleeding will stop. Or you take long piece of gauze and pack the wound tightly. The bleeding will stop. So pressure on the wound or proximal to the wound to restrict the blood supply. For example, in esophageal varicose bleeding, this is achieved by esophageal tamponade. Packing with gauze or available clean cloth. Then allow the patient to have rest and elevate the part that is bleeding. Already I told you, whenever a part is elevated, there will be vasoconstriction. So the vasoconstriction will aid in hemostasis. Tourniquet application. So this is query. This should be done by only trained personnel, not by anyone. So I will tell few words about tourniquet. Tourniquet is indicated to control hemorrhage, to obtain bloodless feel in certain orthopedics and soft tissue operations and in some amputations. Types of tourniquet used during surgery. Sphygmomanometer cuff, X-marks bandage, venous tourniquet, a soft rubber catheter applied to the arm prior to intravenous injection. For example, for the finger, you can apply a tourniquet by a rubber catheter wound like that around the base of the finger. So this is also a tourniquet. Or this is another method of tourniquet. You take a glove towel and then insert it over the finger. This is called the Eschmach's bandage. If you go to the orthopedics department to see the cases of surgery on the lower limb or on the upper limb, first what they do is they exsanguinate the blood from the lower limb. How they tie this rubber bandage. This is elastic rubber bandage. They start from the toes and then they gradually wind it up to the thigh. Once they reach the thigh, then what they do is at this region they place a sigmoid cuff and inflate it. They will inflate it above the level of systolic blood pressure. The systolic blood pressure is 120. They keep the systolic blood pressure at 130 millimeters of mercury pressure. So at that pressure, the arteries will be blocked. So by this squeezing of this with this bandage, all the blood will be squeezed away from the circulation. Then they apply a sphygmomanometer cuff here. Then they take away the bandage. So now the blood is not there in the lower limb. So now this other surgeon will operate upon this in a bloodless field. So once the bloodless field operation is done, it should be done as early as possible. It should be finished off within 40 to 45 minutes. After finishing the surgery, any blood vessels which were cut, they will be repaired or they will be ligated. Then the sigmoid cuff is released. So any bleeding is there will be seen in the wound. So that bleeding will be controlled and wound will be sutured. So to have a quick operation in a bloodless field where operation will be very neat, so this procedure is done. So this is a type of tourniquet. So this is Eschmach's bandage with tourniquet done for the orthopedic operations. So once you apply a tourniquet during surgical procedure, it should be removed once in every 15 minutes when applied to the finger and every 1 to 1.5 hours when applied to the arm. The end of the tourniquet is tied to the operation table to prevent overlooking its presence while the patient is being shifted from the operation table to the ward. I hope you understood this point. When you are doing some surgery on the upper limb or lower limb with tourniquet applied, now you have finished the operation. So operation is being done in the hand. Tourniquet is applied to the arm. So it will be covered by drapes. So you do surgery for 1 hour or 1.5 hours. Then you complete the surgery and then you go away. Then sometimes what will happen, the ward boys and all those people, they just shift the patient without bothering about the tourniquet here. The patient will be under sedation, so he is not bothering about the pain also. If this is there for about 2 hours, the fellow will get Volkmann's ischemic contracture. If that is there for more than 6 hours, the patient will get gangrene of the limb. So to prevent that complication, what you should do is, once your tourniquet is applied here, means the tourniquet must be connected or attached to the operation table with the help of a string. You tie with the string there. So when the patient is being shifted from the table to the stretcher, so the string will be there holding. So then the persons will watch him. Oh, okay, there is a tourniquet here. We have to remove it. So they will remove it and then they will take him. So not to overlook the presence of a tourniquet there, you should tie it to the operation table. That is one safety procedure. Complications of tourniquet, it can be used only around the thigh or arm. It cannot be used over the forearm or the leg. Why? Why it cannot be used? Why can't it be used around the forearm or the leg? No, not like that. In the thigh, in the thigh and arm, there is only one bone and artery is there. So you can tie the two, will cause pressure there. If it is over the forearm or over the tibia, sorry, over the leg, there are two bones are there. The arteries are there between the bones. So you apply a tourniquet, it may not properly hold the artery and it may not be able to completely block the artery. So it will be either partially helpful or sometimes not at all helpful. That is why it should not be tried on the forearm and leg. It has to be tried only on the thighs. Rough usage of it may cause contusion of the arterial wall, especially if atheroma is present. It can cause atheromatous thrombosis over the artery if there is rough handling is being done. Nerve conduction may be seriously impaired. If it is left for more than 1 hour, it may cause muscle death and crush syndrome. It may increase bleeding from the venous ulcers. Hence, it may be dangerous because it may be applied too loosely, too tightly, or for too long. So I told you about first step you have to do is resuscitation, then you have to go for diagnosis of hemorrhage, then you have to go for control of hemorrhage by first aid measures, that is pressure and package, rest and elevation, application of tourniquet, then operative procedures. A patient's severe shock cannot withstand anesthesia and surgical procedures because already his blood pressure is at 50 or 60 or 80 millimeters of mercury pressure. If you give anesthesia, it will drop by another 30 millimeters of mercury pressure. So that will cause impairment to his life also. So that is why you cannot give anesthesia to a shocked patient. So I must revive the patient. So prolonged attempts to revive a bleeding person without surgery can lead to dilution coagulopathy, acidosis, physiological exhaustion. So there, for example, if there is a large amount of bleeding is there, so then what you must do? You must give transfusion. Once you give transfusion, the blood pressure rises. Once blood pressure rises, there will be more bleeding. Again, there is loss of blood. Again, you give blood. So like that, if you go on resuscitating, that is also not good. For example, internal hemorrhage. For external hemorrhage, you can do some first aid measure. For internal hemorrhage, what you do? For example, a bleeding liver is there or bleeding spleen is there. How do you control it? By first aid measures. There is no first aid measure for that. You have to open the abdomen and do something there. That's all. So to open the abdomen, you must give anesthesia. To give anesthesia, you must have at least blood pressure of around 100 millimeters of mercury. To get that 100 millimeters of mercury pressure, you must transfuse blood. If you transfuse blood, there will be more bleeding. More bleeding will cause again fall of blood pressure. So that becomes a vicious circle. That is why you must strike at some point. That is called a critical point. Hence, critical judgment has to be taken to operate when the patient's condition is fit enough to withstand a minimum procedure to stop bleeding and to plan definitive surgery later. This is called the damage control surgery. So in that condition, what you do is you do the most minimum. For example, a patient with hepatoma liver is bleeding. So what you must do? You must stop bleeding, that's all, not remove the hepatoma. I have done abdominal laparotomy open, then without doing any procedure, what is the use? Should not think like that. First, your intention is to save the life. Because there is a quotation, a living problem is always better than a dead certainty. So if you go for hepatoma and then go on operating. In that situation where patient is unprepared, where you are not prepared, where the investigations were not being done, opened the abdomen, found this mass, it is bleeding, so I will remove the mass. So don't be under that impression. You should do the most minimum. If any bladder is there, you ligate it. If there is now no bladder, but there is diffuse oozing from the tumor, then what you do? You just pack everywhere tightly and close the abdomen. That's all. And open it after 48 hours, remove the pack. The bleeding would have been stopped by that time. So this is called the damage control surgery. So not doing a definitive surgery, but do whatever that is needed, the most minimum, to save the life of the patient and stop the bleeding. That should be your intention. I hope you understood the philosophy of damage control surgery. So the operative procedures being ligation of the bleeding vessel if the vessel is not vital. The vessel may be clamped with Spencer-Wells artery forceps and ligated, underrun, transfixed, or coagulated with diathermy. So this is then called the artery forceps, or also called as the hemostat. So if any bleeder is there, you hold the bleeder with this hemostat forceps. Then you apply a ligature. So this is hemostat applied. So you apply a ligature around. Or you do underrunning sutures. This is called underrunning sutures. So under the bleeder, you pass the suture and tie it. So apply 2 or 3 sutures like that and tie them together. So then the bleed will be automatically stopped. This is method of transfixation. Already I explained to you when I was talking to you about the hernia operation. So this is the neck of the sac where you pass the needle in the middle. You tie the suture on one side, then tie it on both around it. If the vessel is important, for example, if the femoral artery that is bleeding or aorta that is bleeding, you cannot just put a ligature for that. So you have to repair it. So if the vessel is vital, you have to repair it. Example, major vessels like aorta, iliac, femoral, brachial, etc. I hope all of you know about these procedures of repair. A minor wound is simply closed. A lateral tear is repaired by vein patch graft. If there is complete disruption, it should be anastomosed by end-to-end anastomosis. If there is disruption with loss of segment, it should be repaired by an interposed venous graft. Repair of injured organ. If the bleeding is from the injured viscus like liver or kidney, that particular organ is repaired. Because liver is a spongy structure bleeding, so you have to repair that structure, but you can't because the individual bleeders may not be ligated there. Then excision of the bleeding organ if the organ cannot be repaired. Example, splenectomy for splenic injury. Packing with long ribbon of gauze soaked in styptics, adrenaline, or saline. So you can soak the gauze with saline and you can pack there. By that you can stop the bleeding. So these are the operative procedures. Then of course you can use surgical diathermy to coagulate the vessels. In some cases you can use gel foam or oxycell to encourage the local coagulation, or bone wax to stop the bleeding from the bone cut edges or bone surfaces. Silver clips to bleeding brain tissue. So these are the methods to stop the bleeding. So ABC is having one doubt, that is what is underrunning. I will explain it again. Already told you, but anyway I will explain it. Now, for example, there is a small bleeder is there and it is giving a gush of blood. It is in the floor of the duodenum, let us suppose. This is the duodenum. So a duodenal ulcer, it has penetrated the underlying gastroduodenal artery and the blood is being pumped out. So here in the wall of the duodenum, you can't hold it with a artery forceps. That is why what you do is you take a suture material on a needle and you take a bite, deep bite, and allow it to come out like this. So this is the thread that has come out and this is the needle connected to it. And similarly, you have another suture like this. So the needle is brought out with the thread, with the suture material. Then you tie them together. So once you tie this thread here, a form knot will be there, and tie this here, a knot will be here. So the underlying vessel will be automatically will be occluded. This is called method of underrunning. So take this suture and a needle and drive the needle under the bleeder. Ligate it. Do at 1, 2, or 3 places till the bleeding is stopped. So this is called underrunning. Okay. Now restoration of blood volume. So I have studied about the control of the bleeding by first aid measures and operative procedures. Now restoration of blood volume. How much to give and what to give? Okay, the patient is in hypovolemic shock. He has lost blood. So how much blood or how much fluid you have to give? In the casualty department, you will not be having a ready stock of the necessary blood for that patient. But blood cannot be given just like that. It should be tested, screened, cross-matched. Then only you have to give it from a donor. So first of all, donor must be available, or donated blood should be available. It should be screened, and it should be grouped and cross-matched with the patient's group. Then only you can give it. So it will take some time. But patient is losing the blood volume. So our intention will be to keep up the blood volume. Though the hemoglobin percentage falls to 7.5 grams percent, there is no harm as long as blood volume is maintained at 5 liters. So our aim will be to restore the volume. Not that blood is lost means we have to give blood. Not that is the principle. Restore the blood volume. So how much to give and what to give? How much to give? It depends upon the amount of blood that is lost during hemorrhage, the amount of continuing bleeding. So how much blood is lost during hemorrhage? So the patient was brought to the hospital from a roadside accident. People have seen the site of the accident and they have seen the bleeding wounds. So all the blood clothes were stained with blood. All the blood stains were there on the face. So still there is some amount of bleeding coming from the wounds. And naturally, whenever blood is there over the face and then over the clothes, every onlooker will think that, oh, this fellow has lost so much of blood, they will say. So that is why there will be a chance of exclamation when you ask about the history from the neighbors or from the patient himself. Even if he has lost just about 10 to 15 ml of blood, the patient will say, oh, I lost about half kidney tray or one dish of blood. So the whole road was wet with my blood. That's what the patient says. So by that statement, you can't go and then give him about half liter or 1 liter of blood. So you have to do your own process to evaluate the amount of blood loss, and if necessary, go for laboratory tests. So measuring blood loss from external hemorrhage, size of blood clots. For example, your professor is doing a major surgery, some surgical oncology procedure. So there was a lot of bleeding during surgery. So the anesthetist was just looking at the patient and he is looking at the parameters. So he was calculating, shall I give blood or not, like that he will be thinking about. But the surgeon is busy with doing his surgery to remove the growth. So he's not bothered about the hypovolemic state of the patient. That is always looked after by the anesthetist. So then the anesthetist should calculate how much of blood that is being lost and how much blood has to be replaced. So what are the measures? Number one, size of the blood clot. So the surgeon is doing surgery on the abdominal cavity. So the whole abdomen is getting filled with blood. The surgeon is taking the blood and then putting it out, or he putting a suction tube and then sucking all the blood, or he's putting a mop there and then taking it out. So there are many procedures to evacuate or empty the blood from the abdominal cavity. So what are the then what the anesthetist should do is he must measure all those things. How? Number one, size of the blood clot. If the blood is thrown away in the dish, the blood will clot. So look at the clot. A clot of fist size is approximately 500 ml. Swab weighing. The mops will be there. The surgeon will be putting the mops in the peritoneal cavity and then mopping. So once mop is soaked, he keep it aside and he will take another mop and he will soak it and again it will be kept outside. Like that. So what the anesthetist will do is now he will collect in the middle of the operation all those swabs. So we'll ask the nurse to keep all those wet swabs outside on a sheet. So he will take a sponge holding forceps and then he will pick them up and then he will weigh them. Usually what the procedure is done in the theaters is every 5 or 10 mops are bundled as one bundle. And that bundle will be weighed before that is being sterilized and sent to the operation theater. And the weight will be marked on the mop. This bundle having 10 pieces, it weighs 1 kilogram. Just I giving a rough idea. 1 kilogram. That means each mop is 100 grams. So that bundle is there. Now the surgeon has used all the 10 mops there. So already previously there was a recorded weight of 1 kg. Now the anesthetist will check these 10 mops, put it in a weighing machine and check how much weight is there. If the weight is, for example, 1.5 kg, that means there is a gain in 500 kilograms. That means approximately 500 ml. That means half liter of blood has to be given to the patient. The swabs used for mopping of the blood during operation are weighed. The gain in weight is noted. Approximately 1 gram weight in the weight is considered as 1 ml of blood. So if 500 grams gain is there, means there is 500 ml of blood is being lost. So the anesthetist takes a paper and that he will note down. Size of the blood clot, there are 2 fist size blood clots. So it is about 1000 ml. The mops are carrying about 500 ml of blood. So altogether it has come to 1500 ml. So 1500 ml means if you don't transfuse with blood, then patient will go into a severe shock. So immediately we'll take a decision to get the blood from the blood bank and they will transfuse the blood. So how much of blood is being lost, that should be calculated like this. The simple anesthetist sits on the head side of the patient and simply announces, "Oh surgeon, you are causing a lot of bleeding. I want to give blood." If you say like that to the surgeon, what the surgeon will respond? No. I am a very senior most surgeon. My surgery is completely bloodless. Those 2 or 3 marks will be there. Don't bother about those things. So surgeons usually underestimate the amount of blood they spill. And of course, the anesthetists, they exaggerate the amount of blood loss. So there should not be any underrating or overrating. It should be correct rating. So that can be achieved by these standard methods: swab weighing, size of the blood clot estimation, then suction. Measuring of blood aspirated in suction bottles during surgery. You can measure how much blood is being collected in the suction apparatus. So these are the ways by which you calculate the blood loss during surgical procedure. If there is internal hemorrhage, then how do you calculate the blood loss? It's difficult, isn't it? You are not seeing anything. So there is bleeding in the peritoneal cavity. How much blood is lost? How can you say? Unless you open the abdomen, you can't say. So then there is a rough guide for that. In case of fracture of the limbs, moderate swelling of the leg in fractured tibia or shaft of the femur equals to about 500 to 2000 ml of blood. In internal hemorrhage, that means into the abdominal cavity or into the pleural cavity, the loss is estimated by clinical parameters and vital data. Already have given class 1, class 2, class 3, class 4 shock. What will happen if blood loss is less than 750 ml? 750 to 1500 ml, what are the clinical manifestations? From 1500 ml to 2500 ml, what are the clinical parameters? More than 2500, what is the clinical parameter? So already I explained to you. So there are 4 classes of shock. So by looking at the parameters, you roughly come to a guide how much of blood is being lost. So you got an idea. The patient has lost about 1000 ml of blood. So what to give? If blood is lost means you have to give blood only. Blood is not immediately available. You can't wait without giving anything till the blood comes. So what you should do? You should give fluid. So depending upon the quantity of blood loss, you have to give blood or fluid transfusion. Usually, loss of more than 750 ml of blood needs blood transfusion. Less than that doesn't need blood transfusion if patient doesn't have any previous comorbidities. So pending blood transfusion, IV crystalloids or colloids are administered. So IV fluids are given. So there are 2 types of IV fluids. They are crystalloids and colloids. So either you give crystalloids or colloids. Later, the estimated loss is corrected by blood transfusion with monitoring of vital signs. So once the blood arrives, then you give the blood transfusion. So to restore the blood volume, so you give the fluids. What is the rationale of giving fluid when blood loss is there? The rationale is a hemoglobin of 7 grams per centiliter is adequate to deliver adequate oxygen to the tissues if the circulating volume is normal. So our intention is to keep the circulating volume is normal, even by diluting. Even by diluting hemoglobin, we wish to maintain the circulatory volume. If the volume is maintained, patient will not go into shock. Once the blood comes, it may take about half an hour or 1 hour for you to procure blood. Till that time, you keep the blood volume of the patient at 5 liters by infusing IV fluid solutions with electrolytes. So how to give this IV fluid assistance? First of all, you must record the baseline vital data. So when the patient has arrived to the hospital, you record the baseline vital data. What are the vital data you have to record? Sensorium of the patient, color and warmth of the extremities, pulse rate, and blood pressure. So you record them. Then after 15 minutes, you record again. Then you can say whether patient is progressing or deteriorating. So once you record it, then you assess the cause of the shock. Now resuscitation is started. It depends upon the type and severity of the shock. If initial doubt about type of shock is present, it is assumed as hypovolemia and resuscitation started, reassessed and managed accordingly. That means if the patient is brought in shock condition, there is no external evidence of any hemorrhage. It may be myocardial infarction or internal hemorrhage. So, but usually what you do is, whenever a patient comes in shock, you assume that it is hypovolemic shock and start IV fluids immediately. Don't waste time till you make a diagnosis whether it is cardiogenic shock or hypovolemic shock. You start IV fluids. So once you start IV fluids, then you do the necessary investigations to make a diagnosis whether it is a cardiogenic shock or a septic shock or hypovolemic shock. Then you adjust the fluid therapy accordingly. So initial resuscitative measure for circulatory assistance in a shocked patient, irrespective of the type of the shock, neurogenic shock, cardiogenic shock, septic shock, hypovolemic shock, initial resuscitation is with fluids and electrolytes. Position of the patient is kept in supine and Trendelenburg's posture. Elevation of lower limb aids in emptying of the large capacitance veins of the lower extremity, increasing the effective circulating blood volume. This will save lives in many patients. Elevation of the lower limbs. So whenever a patient is brought to you in shocked condition, so usually what the attendants will do, they will bring him holding on both hands and pulling him or dragging him, he will be brought to the casualty. If that is the situation, immediately you must make the patient to lay flat on the table. Then you must ask one or two attendants to come and then hold the lower limbs straight upwards. So if you elevate the upper limbs upwards, the blood will drain away from the capacitant veins by gravity into the central veins and cardiac input will increase, or venous input will increase into the right atrium. So this is a very, 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 very important step which you should never forget in your life. As long as you practice, as long as you live as a human being, if any person is seen with shock, so immediately keep him onto the table, or if table is not there, allow him to lie on the ground or push him onto the ground and elevate the lower limbs. That should be done immediately. But in many situations, what you see on the roadside accident, a fellow is accidentally involved in a road traffic accident. That fellow is driving a motorbike, a skid, and has fallen on the ground. So he's not talking anything, let us suppose. Immediately what the people will do? He will rush to the site. There will become a big crowd around the fellow. And one or two fellows, they will go to that fellow, they will make him sit, and they will slap on his cheeks. Wake up, wake up, wake up, or speak out, speak out, speak out. Don't go to sleep, don't go to sleep. Like that they will say. It's all unnecessary trash. What they must do, they must keep him flat on the ground. See whether the fellow is taking normal respiration or not. If he is not able to take the respiration, it is noisy respiration, means there is some obstruction. So immediately you must see what the obstruction is there in the airway passage, you must correct it. Then see whether chest is moving freely or not. The chest is moving freely, okay, otherwise you have to assist his breathing. Then one or two fellows should go to the leg side and then keep the legs elevated, lower limbs elevated. That will cause capacitant veins, they're empty. So we have seen about 60 to 70% of blood volume will be there stored in the capacitant veins. So once you elevate the limbs, they get emptied and the venous return to the heart suddenly resumes to the normal level and patient's shock will recover. So this you must always do it. Okay. So position of the patient, patient is kept in supine position with limbs elevated. Intravenous fluid administration. Aim to achieve normovolemia as early as possible because shock is dependent upon the degree of volume reduction. Again, a hemoglobin of 7 grams per cent is adequate to deliver oxygen to the tissues if circulating volume is normal. So repeatedly this statement is being made to give an emphasis on your brain that for a bleeding patient, there is no need to wait till blood comes. You must immediately start him on IV fluids. That is what the message I want to give to you. Even if you give IV fluids, the blood volume will be restored. When the blood volume is restored means there will be reperfusion for IV fluids also. Not only for the blood, even for IV fluids also, the reperfusion syndrome or injury can take place. So this reperfusion injury occurs not in every case. This occurs in a patient who is in severe shock for a prolonged period. If the patient is being resuscitated immediately, then there is no question of anaerobic metabolism and their metabolites accumulation in the peripheral tissues. So there is no question of any reperfusion injury. So in hemorrhage, pending blood transfusion, IV fluids are infused initially. The initial volume replacement can be achieved with crystalloids or colloid solutions. Majority of the intensivists, they prefer crystalloid solutions. Colloids, once upon a time, it was being used by few surgeons, but nowadays it is not being recommended. But the recommended procedure is with the crystalloids. So what is meant by these crystalloids? And how much you have to give and what to give. So for this, you should have little bit basic knowledge about fluids and electrolytes in the body. Not only that, how the fluid is distributed and how the fluid is being transported in the blood, in the body itself. Fluid is a dynamic structure. It is not like that. To be moving between blood vessels and extracellular spaces, that is ECF. Then it will be moving from the extracellular fluid into the cells and is moving out of the cells. So there are three compartments are there in the body. Mainly there is extracellular and intracellular compartment. Within the cell, outside the cell. So now let us see here, 50 to 60% of the body weight, that means approximately about 45 liters in a 75 kg individual, is by water. In this 45 liters, 30 liters is there in the cells, that is intracellular fluid, and about 15 liters is there in the extracellular space. So outside these cells, the fluid is again divided into two compartments. This is the blood compartment that is there in the blood vessels. So in the vessels, it is about 3.5 liters. With the fluid, 1.5 liters, of course, the blood is the RBC. So total becomes 5 liters. So 3.5 liters is the fluid component of the plasma. Then about 11.5 or 12 liters is the interstitial space, fluid. So we have three compartments here. Intravascular space, interstitial space, and intracellular space. Just see the ratio between these distribution. 9:3:1. Intracellular is 9, interstitial space is 3, and intravascular space is 1. So it is 9:3:1 ratio. The fluid is being distributed among these three spaces. Now, the intravascular space is separated from the interstitial space by means of capillary membrane. The capillary membrane is having pores. It is permeable to certain structures. So it is permeable to water and crystalloids. So crystalloids will move this way and this way freely. That's why they will be in equilibrium here. That means if the sodium is elevated here, automatically the sodium gets elevated here. If the sodium is elevated here, it gets automatically elevated in the interstitial space. So both of them are in equilibrium. But the colloids, whose molecular weight is more than 60,000, they can't cross this capillary membrane and come into the interstitial space. So they are blocked by the capillary membrane. So they retain themselves in the intravascular space without getting moved out. Of course, there is a third space in the interstitial space. Let's not bother about third space here. So that is the distribution of the fluid. Now transport of the fluid. You may be thinking why I am telling all these things to you now at this place. To understand what type of fluid you have to give, how much of fluid you have to give, you must know these basic principles. That is why I'm telling these things. Once you learn this, then you will understand the importance of knowing this basic physiology. Okay, transport of fluid. Fluid passes across the compartments depending upon the following factors. Osmotic tension, that means electrolytes, proteins, and solutes, they follow this osmotic tension. Then hydrostatic pressure, then cell membrane integrity. So these three things will determine. So cell membrane integrity means is by presence of sodium pump. Already we have discussed about sodium pump in the previous class. Osmotic effect. I hope all of you know about the osmotic effect. Let's suppose you take a big chamber separated with a semi-permeable membrane. Water in both the compartments, they will become equal level. They will come to the equal level. Now add some salts to this compartment. So what is happening here? The osmotic pressure is increased here. So with this, the water shifts from this compartment to this compartment. And this compartment will rise. So till their osmotic tensions become equal, the compartments will be moving. Hydrostatic pressure means hydrostatic pressure at the capillary ends. We have seen yesterday the arterial end capillaries and venous end capillaries, they have pressure. That pressure is transported from the heart. Cell integrity also we have discussed yesterday. So this is potassium in the cell, sodium outside the cell. So sodium is always pumped out. This is because of ATPase. That means there is an enzyme that is called NAK ATPase. So in sick cell, when the cell has become sick, then potassium flees and sodium stays in the cell, and water flows along with sodium. Calcium enters the cell, intracellular lysozymes break down, leading to cell damage. So if the sodium pump fails, then ultimately cell damage takes place. Now, we have seen these three compartments in a ratio of 9:3:1. If you add some fluid here to the vascular compartment, if you want to give anything to the body, you will give it through only blood circulation. Even if you take by mouth, that goes into the blood only. Or you can give intravenous administration. So for example, you have given fluid into the blood compartment. Then what will happen? It will get distributed equally if the capillary membrane permits the fluid to pass through. So sodium-free solution. So that means there are no electrolytes, just plain water you have added. It gets distributed equally among three spaces. Equally means to the same level as per their proportion. We have seen the proportion is 9:3:1. So if you are given 1 liter, that 1 liter will be distributed in this ratio of 9 parts go to the intercellular space, intracellular space, 3 parts will be going to the interstitial space, 1 part will be remaining in the intravascular space. If you give a sodium containing solution, it gets distributed only among the interstitial space and intravascular space. It won't go into the intracellular space. Why? Why it doesn't go into the intracellular space? What about others? What about others? Yes, that's good. The sodium pump will not permit the sodium to enter into the cells. So that is why sodium containing water doesn't go into the cells. It remains only between the interstitial space and intravascular space in a ratio of 3:1. Then we will take other type of fluid, that is a colloid whose molecular weight is more than 60,000. You tell me what will happen. You have administered colloid into the intravascular space. Very good. Only it remains in the, very good. Only it remains in the vascular space. Very good. So we have three types of fluids. One is electrolyte-free solution. There are no electrolytes. Number two, electrolyte, the sodium containing fluid. Number three, the colloids. So for example, if you are given 13 ml of fluid is administered, how it gets distributed? Let's see. If you give sodium-free solution, 9 ml go into the intracellular space, 3 ml into the interstitial space, and 1 ml into the intravascular space. Sodium containing solution, it is distributed in a ratio of 9:4 between the interstitial and intravascular space. 9:4 means approximately it comes to 3:1. Then if you give only plasma or colloid, then that is there completely within the vascular space. So volume replacement with crystallized solution is calculated on a 3:1 ratio of replacement to loss. So a patient has come to you with hemorrhage. You have immediately kept him on the bed, elevated the lower limbs, started IV fluids. That means you put a cannula, draw the blood for basic blood tests. So a patient whenever comes to you with history of bleeding, immediately you must make him rest on the bed, elevate the lower limbs. Then you must push him a cannula into it, IV into that means you must get intravenous access with a cannula, draw blood and keep it aside for basic tests like hemoglobin percentage, blood grouping and cross matching, then electrolyte estimation, hematocrit estimation, acid base disturbance. So those should be checked. So you keep it aside and send it to the laboratory. And then you connect with a fluid. So if you are choosing a crystallized solution, you must run the fluid. Then you estimate how much blood the patient has lost by the parameters. We have seen the parameters. The pulse rate, the blood pressure, the urine output, the warmth of the skin, the cyanosis, then whether patient is anxious or calm. So basing on that, you can calculate the amount of blood that is being lost. That is, of course, it is an approximate guide. So let us say it is 1 liter. So 1 liter of blood is lost. So the patient has got injured around 6 o'clock in the morning. He was brought to you around 9 o'clock. So you examine the parameters. Of course, you examine the parameters after you connect the IV fluids because first of all, resuscitation is important. Then you check the parameters. So the parameters are showing like that. So they indicate that the patient has lost around 1 liter of blood. Okay. You order for the blood. You don't know the group. So you have drawn the blood, you check for the blood grouping, then you get request for blood cross matching and transfusion. Before the blood comes, it takes about 1 hour or 2 hours. You must keep the blood volume at 5 liters or near 5 liters. So how much blood you have, how much fluid you have to give? Your estimated loss of blood is 1 liter. So now how much crystallized solution you give? You tell me. The patient has lost 1 liter of blood. That is your estimation. Blood is not available immediately. So you have started him on intravenous crystalloid solutions containing sodium. That is normal saline or Ringer's lactate solution. These two are the sodium containing solutions. So now you give for 1 liter of blood loss, how much you have to give? How much of fluid you have to give? What about others? Shanti, Nizami, others, please also answer. Manogya and Shanti has answered it as 9 liters. Why? 3:1. So 1 liter is lost. How much you have to give? 1 liter is lost. How much you have to give? Yes, you have to give only 3 to 4 liters, not 9 liters. You make 3, 1, add them, 3 plus 1, 4, total 4 parts. One part is lost. So for replacing one part, you have to give 3 parts. That means you have to give 3 liters, approximately 3 to 4 liters. Because this intravascular space and interstitial space is not so accurate what I have given the figures there. That is, a range will be there. If I tell the range, you get confused. That is why I have given it as only 3.5 liters volume intravascular and 25 liters volume or 30 liters volume in the interstitial space. That is what I have given. But it's not like that. It will be a range, will be 30 means it will be around 25 to 35. That will be the range. So approximately you have to give about 3 to 4 liters of sodium containing solution for each liter of blood loss. So that is what you must understand. So for 1 liter, you give 4 liters. Ring electrode is preferred crystalloid because of its similar composition to the plasma. Because ring electrode is having the same composition as that of the plasma. Of course, I have not told you about the electrolyte balance in the blood. I will tell you in the next class. So for the time being, please remember that the ring electrode composition and plasma composition of electrolytes are almost similar. That is why you prefer to give you must give the crystallite solutions in form of Ringer's lactate. As ABC, you have a doubt. 1 liter blood loss means we should consider it is only intravascular. Where from else blood can bleed? Tell me. Apart from vessels, is there any other source from which blood can bleed out? Okay, there are 3 compartments are in equilibrium, but when whole blood is lost, where from it loses? It is lost from the vessels only, blood vessels only. So I will give an example. Blood vessel capacity is 5 liters. Patient has lost 1 liter of blood outside. So what will become to is the vascular capacity? It becomes only 4 liters. That means the veins gets constricted, make the space smaller. So it is only 4 liters. But this is a human body where there are a lot of compensatory mechanisms. Because of the compensatory mechanisms, there will be shift of fluid from the interstitial space into the blood compartment later. It takes some time. So before the patient manifests with the features of shock or hypovolemia, you must resuscitate him by giving electrolyte fluid intravenously. So whenever you are opening the abdomen means it is not a minimal operation, it is a major operation only. But if there is internal hemorrhage into the abdominal cavity, then the most minimum which you can do in your circumstances, if you're in a small nursing home, Where facilities are not much available, you open the abdomen and then do packing. If you are in a very sophisticated hospital where all facilities are available for intravascular invasion also, then you can do therapeutic embolization. You need not open the abdomen, you just embolize. So that all depends upon the facilities available. Whatever the most minimum that is feasible and possible and within your limits, you do it. Your intention is mainly to save the life of the patient. If you think that the patient can be shifted to a place where therapeutic embolization can be done for a bleeding liver tumor, the patient can survive for the distance, very good. You can transport him with blood transfusion in place. If you think that the patient cannot survive for such a long distance and is very, very long away, then you must operate and then pack the wound. Aspiration means, do you mean to say aspiration from the abdominal cavity? No, I can't get you. What do you mean by aspiration? Okay, the blood in the abdomen is that is what I'm talking. If possible, you can do the aspiration, but it is very difficult to aspirate by a needle because some of the blood will be clotted that won't come out so easily. So you have to open the abdomen or make a small incision and then by that only you can evacuate. So if the blood is there in the peritoneal cavity, up to 3 liters, there is no problem. If it is more than that, that causes respiratory embarrassment. So up to 3 liters means if the patient, usually he will not survive more than 3 liters is there in the peritoneal cavity, he will die of shock, severe shock. Yes, we have to give anesthesia also if you want to do any surgery on the patient. Okay, let's come back to the topic, volume replacement. So volume replacement initially should be done with crystallized solution, preferably Ringer's lactate, because its composition is similar to that of the plasma composition. It is given in a ratio of 3:1 approximately, or 3 or 4:1. If you have choose to give colloids, you must give in a ratio of 1:1, as they are not passed across the capillary's membrane because of the high molecular weight. Present day studies show that colloid administration is not advocated as they are expensive and have more side effects. Even if you want to give, you should not give more than 1.5 liters per day. Colloids are also not excreted by the kidneys like electrolytes. Ringer lactate, if you are given, for example, you are given 4 liters. So already patient has lost 1 liter of blood. You are given 4 liters of Ringer's lactate. That means the vascular volume has come to 5 liters. Now the patient, you got the blood for transfusion. If you give the blood, it will become more, isn't it? No harm or no problem with Ringer lactate. Why? Because it can be excreted by the kidneys. So you wait for half an hour, the Ringer lactate will be excreted and you can give slowly blood transfusion. If you want immediately, you give 1 dose of a diuretic to the patient. So all the fluid will be excreted out. Then you can give the blood transfusion. So crystallized solutions can be maneuvered. But colloid solution, if you give 1.5 liters, means if you get blood, you can't give blood because already space is full with colloid solution also. The 5 liters is full. You can't give blood now. If you give blood means it becomes over transfusion. It becomes overload on the heart. You can't get rid of colloids. but crystalloids you can get rid of. So that is one best advantage of crystalloids. Examples for the colloids being albumin, plasma, synthetic substances like dextran, gelatin, hydroxyethyl starch. The side effects of the colloids being sensitization reaction, interference with cross-matching and coagulation, may aggravate ARDS. Plasma, there is albumin, you carry the risk of transmission of infection. If estimated blood loss is more than 750 ml, whole blood transfusion is given as soon as cross-matched and screened blood is available. So that is the resuscitation. So the resuscitation should be given initially with intravenous crystalloid solution, preferably Ringer's lactate in a ratio of 3 to 4:1 loss. If the blood loss is more than 750 ml, arrange for blood transfusion. Once blood is received, you transfuse with the blood. How fast you give the blood or how fast you give the fluids, that all depends upon monitoring of the patient and response of the patient. For example, the patient has lost 2 liters of blood by the time he has come to your casualty. So there is 2 liters deficit is there. Then the 2 liters should not be pumped all of a sudden. Because in this 2 hours time, though the patient has lost about 2 liters of blood, there are some compensator mechanisms working in the body, which is trying to replenish the blood volume. So if all of a sudden, if you make it 2 liters suddenly, then there will be some problems. So it should be given very fast in some cases, slowly in some cases, and gradually in some cases. How? That all depends upon the patient's response. What is the response? The response by vital parameter monitoring. That is why, as you are giving the fluid, you must have a constant check on all vital parameters. The speed and quantity of administration of fluids or blood is guided by monitoring the vital parameters. Concurrent efforts are made to control the fluid deficit by pharmacological, physical, or surgical methods. So monitoring is done by quarter-hourly or half-hourly basis. Sensorium of the patient, pulse rate, rhythm, and volume, the blood pressure. Then the urine outputs. Examine the rails at the base of the lungs. For crepitations means crepitation of the lungs means there is overload in the lungs. Similarly, jugular venous pressure recording do not reveal accurate results. This was done previously. So in case of CVP, that means you do central venous pressure monitoring is indicated in transient and non-responders. Of course, I will tell about these things later. Then continuous blood pressure monitoring by intra-arterial line. Swan-Ganz catheter monitoring is replaced by Doppler scan. So the main things, the utmost minimum what we have to do is pulse rate, the blood pressure, sensorium of the patient, warmth of the patient. Next, most important is urine outputs. Hourly or half-hourly urine output. 1 ml per kg per hour, that should be your aim. So that should be there. So these things must be evaluated. Sometimes the patient, you are giving more fluid or more blood. So if it is more than 1 liter or 2 liters are there, sometimes it may be a over transfusion or it may be a rapid transfusion, which can cause a lot of bad effects on the heart. So they should be counter-checked by CVP, central venous pressure monitoring. So whenever large volumes of fluid or blood being administered, they should be administered by CVP monitoring. I hope all of you know about CVP monitoring. Yesterday I told you about CVP monitoring. Normal should be 5 to 12 or 15 centimeters of water. So it should not be less. Should less means the space is less. That means less of volume is there, so you add more volume. If it's more than 15 centimeters of water means it is more tight. That means you should reduce the fluid input or stop the fluid input. So continuous monitoring of pulse rate and oxygen saturation by pulse oximetry along with hourly urine output measurement is mandatory in every case of shock. Then I will tell you a few monitorings for organ perfusion also. So the best monitor for organ perfusion is or visceral perfusion is renal output. But in some advanced centers where there is severe blood loss or where patient is having a lot of other comorbidities, this monitoring also will be done. That is base deficit, lactate levels, and mixed venous saturation. So already we discussed about this. Urinary output, muscles, near infrared spectroscopy, tissue oxygen electrode, gut sublingual capnometry, gut mucosal pH, laser Doppler flowmetry, brain tissue oxygen electrode, near infrared spectroscopy. So these are all only the experimental and more advanced techniques. You need not bother about them to know. Monitoring of organ perfusion by estimation of lactate, base deficit, mixed venous oxygen saturation helps to resuscitate wisely as there may be occult tissue hyperperfusion with normal bedside parameters and increased organ perfusion parameters. So why you do monitoring of organ perfusion? So the best parameters for organ perfusion is urine output, that is quite agreed. Apart from that, there may be some occult tissue hyperperfusion even with normal urine output and normal bedside parameters. But that occult hyperperfusion of the tissues can be evaluated by estimation of lactate levels and automatically base deficit. That means how much acidosis is, metabolic acidosis is there, and by calculating the mixed venous oxygen saturation ratio in the major veins. So they will tell you about the perfusion status. For that reason, these things can be done. So far we have discussed only resuscitation is fluid or blood replacement, stopping the bleeding. So that's only what we have read so far. In addition, monitoring to judge for the speed of transfusion or infusion. Infusion means fluid infusion. Transfusion means it is blood transfusion or blood products transfusion. Ancillary treatment, oxygen administration, because patients will be usually hypoxic in shock, so you supplement oxygen by mask or by nasal catheter to correct hypoxia, to maintain oxygen saturation at 95%. Then drugs, pain relief by giving intravenous injection of morphine or pethidine diluted in 10 ml of saline. So this morphine or pethidine should be administered intravenously slowly by titrating. So the meaning of titrating is you give such a dose to make the patient adequately sleep. So till he is put to sleep, up to that only you have to give the injection. There is no fixed dosage. So per address at a speed of 2 ml per minute, that means slowly, very slowly, you give the drug intravenously. Acidosis correction. It is usually corrected by improved tissue perfusion following volume replacement. Acidosis is estimated not to correct it, but to evaluate the tissue hypoperfusion. Acidosis will be there whenever there is tissue hypoperfusion. So if we measure acidosis, that will tell you how much tissue hypoperfusion is there. So how do you correct it? So once the perfusion is corrected, acidosis also gets corrected. For that, you should not give alkalizing solutions. If it is severe, less than 7.2, then corrected by IV administration sodium bicarbonate. Then vasopressors or inotropes. Now, in the essence of shock is fall of cardiac output. So instead of waiting till the cardiac function resumes by giving sufficient amount of fluid or blood, increasing the venous return, then you estimate the cardiac output will increase. So why to wait like that? Then some people, what they did was, instead of waiting like that, let us stimulate the heart with inotrope. The heart will powerfully contract. That will correct the shock. That's what they thought, but it won't work. So inotropes, they are not indicated as first-line therapy. So the inotropes are not indicated as first-line therapy before preload correction. So first of all, you must correct the preload, as they can cause decreased myocardial perfusion. They are indicated in distributive shock, that means in neurogenic shock and septic shock, where there is high output shock with peripheral vasodilatation, and also in cardiogenic shock to improve the cardiac contractility by inotropes. So in simple hypovolemia, the first preference should be for fluid replacement. The inotropes has no role in the initial setting. It is not given in the initial setting. Inotropes are indicated only in the neurogenic, septic shock, and in some case of cardiogenic shock. Miscellaneous precautions: you should avoid sudden warming of the patient by too many blankets, by avoiding alcohol consumption by the patient, sudden change of posture from recumbence to sitting or standing posture, anesthesia till cardiac output is stabilized. These factors, because these things will cause vasodilatation, nullifying the vasoconstrictor effects of the compensated shock. So before I go to the summary, Sandy has given a big doubt here. So first of all, I'll clear them. As in any stage of the shock, the capillary permeability increases. So colloid solution can pass into the interstitial space. So it can also be a reason for not choosing the colloid solution. Of course, it is not the only reason, mainly because of the side effects and non-flexibility. How will we calculate in volume by acidosis? What is the normal sodium bicarbonate level? What is the normal level of sodium bicarbonate in the plasma? Okay, it seems you are not aware of it. It is 25 milliequivalents per liter. 25 to 30 milliequivalents per liter. So a patient with shock comes to you. estimate his bicarbonate level. If the bicarbonate level is, suppose it is 20 milliequivalents per liter, that means there is 5 milliequivalents deficiency is there. So 5 milliequivalents deficiency means patient is having tissue hypoperfusion. That is called base deficit. So what is the base deficit? 5 milliequivalents. So with the base deficit of 5 milliequivalents, the patient will have the hypoperfusion. Correct the hypoperfusion by various monitors, what I have already told you, by IV fluids, by blood transfusion, and by oxygenation. So it is the acidosis is helpful to know about the hypoperfusion status of the tissues. That indicates that they are undergoing anaerobic metabolism. So that is what we get information. That won't tell you how much of fluid you have to give. So that is not indicated by the acidosis. So measurement of acid-base distribution, that is soda bicarbonate, is mainly to know about the perfusion status of the tissues. It won't tell you about the volume of deficit. You said some 500 ml. What is it, Santi? Okay, Afrin is having one more doubt. In internal hemorrhage, what if the BP is low? How can we give anesthesia for surgery if BP is low? How will we manage BP? Very good. In internal hemorrhage, your idea is that the bleeding is not being controlled, still it is continuing. The abdomen is getting distended, and you have to operate upon the patient. But BP is gradually sinking down. Anesthesia cannot be given because BP is low. So how to manage this case? So that is your doubt. That is why what you must do is, you must give a rapid transfusion of IV fluids and later blood. How long you give it? Till the blood pressure comes to around 100 millimeters of mercury pressure and pulse rate comes to about 100 per minute. Between 80 to 100 millimeters of mercury pressure, your blood can be maintained, then patients can be given anesthesia. The anesthesia that is given is not the standard type of anesthesia. They give anesthesia in such a low plane that they do not use much of the vasodilating effect of the anesthetic drugs there. They use very few or sparing drugs which have the vasodilator effects. So at that optimum blood pressure level, you operate, keeping the blood and fluid ready by your side. Once you open the abdomen and allow the blood to come out, so suddenly the blood pressure will fall. So then immediately you must manage it by infusing fluids or blood rapidly. So there should be a continuous monitoring of the pulse rate, blood pressure, oxygen saturation. And ventilator capacity is under control of anesthetist. So he is controlling ventilation, oxygen. So by that, so everything is under control. Then once the blood pressure has come to 100 millimeters of mercury pressure, you open the abdomen and do the surgery. And once the surgery is being done, so any fluctuations in the blood pressure is being corrected by rapid administration of fluids or blood, if necessary, by inotropes. So inotropes will also be ready by the side of the anesthetist, because some of the drugs have vasodilatory effects. So to counter the vasodilatory effects of those things, so he will use inotropes also. So it is a balanced exercise. Is it clear? Okay. So summary of management: airway and breathing assessment and correction, IV cannulation, blood drawn for hemoglobin percentage, PCV, electrolytes, coagulation profile, grouping and cross matching. Ringer test started. Bleeding site and quantity assessed. For internal bleeding, imaging is advised, and first aid procedures are adapted to control bleeding. Blood transfusion is given if glass of blood is more than 750 ml of blood, or else crystalloids are administered pending blood transfusion 3:1 ratio. Quarter hourly or half an hourly monitoring of vital data is done, and the speed and amount of transfusion is adjusted. After appropriate resuscitation, surgery is planned to correct the bleeding. So I said appropriate resuscitation, not after complete resuscitation. So if the patient is around between 80 to 100 millimeters of mercury pressure and pulse rate is between 100 to 110 per minute, then you can operate upon the patient with anesthesia. Management of complications. Oliguria. So yesterday we discussed about the oliguria. So we will now discuss about the management of this oliguria. Okay, Manogya has a problem. She lost connection, it seems, and she was unable to see the summary slides. So she wants to see the summary slides. So these are the summary slides. So these are the two last slides. Now management of complications. Oliguria. So before I tell the management of oliguria, I will ask you a question here. A patient with stroke came to you. You have put in a catheter, some urine drain. Then you connected the catheter to a urine collecting bag for quarter hourly recording of urine outputs. The person was weighing around some 70 kg. So after quarter of an hour, you have seen the urine output. The urine output is only 5 ml in 15 minutes. That means roughly it works out to be 20 ml per hour. Now, what can be the cause? Oliguria. So you call it as oliguria. So what are the causes of oliguria in a shock patient? Okay. What everything you have said, I will summarize here. The first cause of oliguria is reduced blood volume. Whenever there is reduced blood volume, there is reduced glomerular filtration rate. Whenever there is reduced glomerular filtration rate, there will be reduced urine output. That is one simple cause. There is no fluid intake. What will happen? There is oliguria. Even for us in summer, if we don't drink water and going on doing some work, then there will be oliguria. So, number one, there is hypovolemia. That is the cause for the oliguria. Number two cause is because of the renal vasoconstriction. The patient is going to this stage of compensatory shock. As a compensatory phenomena, there is peripheral vasoconstriction, splanchnic vasoconstriction, and renal vasoconstriction. So, because of the renal vasoconstriction, there is reduced blood flow into the glomerulus, and that causes reduced GFR and reduced urine output. So, that is the second cause. Then third cause is the reduced perfusion is not corrected. It was there for more than 1 hour or 1.5 hours. So that has resulted in damage to the tubular epithelium, causing anoxic tubular necrosis. So oliguria in a patient with shock can be due to reduced blood volume, renal vasoconstriction, and renal tubular necrosis. So when you look at the urine output tube, can you say which is the cause out of these three? You can't say. That's why there are steps in the management of oliguria due to shock. What are these steps? First thing is exclude hypovolemia. So of course these are the complications: oliguria, ARDS, stress ulceration, unresponsive myocardium, and MOTS. Oliguria. So the cause of oliguria and shock is due to reduced blood volume, reduced cardiac output, reduced GFR, renal vasoconstriction, tubular necrosis. So these are the three causes. So first what you must do, ensure adequate volume replacement. How do you know you have replaced the volume correctly or not? CVP. If CVP is 12 centimeters of water, then that means you have adequately replenished the circulation. So give fluids till CVP comes to 12. Urine output resumes. If our urine output is not resumed, means it is not the only cause, there is something else. For exclude obstruction of the urinary passage, give renal dose of dopamine, that means 3 to 5 micrograms per kg per minute. So this dose of dopamine you have to give to increase the cardiac output as well as to cause renal vasodilatation and increase renal perfusion. Give a loop diuretic of furosemide 40 milligrams IV initially, increasing to 120 to 240 milligrams IV. Avoid nephrotoxic drugs. If these measures fail, treat the case as acute renal failure. That means fluid and electrolyte restriction, dialysis. So this is how you manage the case of oliguria in shock patient. This is a very important topic, quite frequently given in the theory examination, and quite frequently you encounter during your practice, either as an house surgeon or a postgraduate, later as a medical practitioner in any specialty. So you should know about this. As a surgeon, you do some surgery. You keep the catheter. Urine output is not there. You are very much worried. So whether it is due to the less of fluid, or patient has gone into shock, renal vasoconstriction is there, or the patient is gone into renal failure. So these things will be there in your mind. So this is the method by which you go stepwise and you will be safe at treating the patient. ARDS. This is also called as respiratory failure. So the method is ensure adequate airway without any collection, give mechanical ventilation, then monitor blood gases, administration of IV fluids under CVP monitoring. If you give more fluids, the patients will develop aggravation of ARDS. That is why you should not give more fluids. You must always give adequate fluids. So how to give adequate fluids? The adequate fluid therapy is achieved by CVP monitoring. Now can you see the slides? I have refreshed the screen. Are you able to see the slides now? Then stress ulceration, H2 blockers, omeprazole, pantoprazole, etc. Improving splanchnic blood flow by dopamine, sucralfate orally. Unresponsive myocardium. Unresponsive myocardium means you have given adequate amount of IV fluids or adequate amount of blood transfusion. You have followed the ancillary measures, but the myocardium is not contracting and is not giving the optimum output and blood pressure is still low. So in spite of adequate volume replacement judged by CVP and PAWP, if the cardiac output is not adequate as indicated by pulse rate, blood pressure, urine output and skin temperature, then the vasoactive drugs are administered, that means the inotropes. So the inotropes being, you can classify them, these are the adrenergic receptors in the body, alpha, beta 1 and beta 2. Alpha stimulation causes vasoconstriction, pupillary dilatation, gut relaxation. Beta 1 stimulants cause cardiac acceleration and inotropic effect. Beta 2 receptor stimulation cause vasodilatation, bronchial relaxation. So there are varied effects by the stimulation of adrenergic receptors. Probably must have studied them in your physiology as well as in your pharmacology. Norepinephrine is a pure alpha stimulant. Adrenaline is predominantly beta stimulant and plus alpha stimulant. Dopamine is having dose-dependent action. So the dopamine, dopamine, noradrenaline, they are called the inotropes. Adrenaline is not used as an inotrope because of its mixed reaction on the alpha as well as beta. Dopamine, the effect depends upon its dose. 2 to 5 micrograms per kg per minute, that is called the renal dose. It is a powerful inotropic effect on the heart with renal vasodilatation. 5 to 10 micrograms per minute stimulates beta adrenergic receptors, causing increased inotropic effect with mild vasodilatation and mild chronotropic effects. 10 to 20 micrograms per kg per minute causes stimulates alpha receptors, increased inotropic and chronotropic effects, arterial and venous constriction, leading to decreased end organ perfusion. So it is a dose dependent. So usually 2 to 5 micrograms is usually used. Dopamine, dose 2 to 20 micrograms per kg per minute, strong inotrope with pulmonary and systemic vasodilatation, and minimal tachycardia with no effect on the renal blood flow. Norepinephrine strong inotropic effect with intense vasoconstriction and minimal tachycardia, indicated in distributed shock like septic shock, neurogenic shock, where there is peripheral vasodilatation with low systemic vascular resistance, leading to low blood pressure. Vasodilator drugs, these are rarely used under expert intensivist management. Management of MOTS. So the patient has already slipped into a dangerous sequelae, that is MOTS, multiple organ dysfunction syndrome. So then how to manage? SIDS is the main mediator of MOTS. Many therapeutic trials are under study. Some of these are corticosteroids, arachidonic acid metabolite inhibitors, free oxygen radical scavengers, improved gut perfusion. So these are the measures that are taken to correct the MOTS. So this is about management of hypovolemic shock. Any doubts, please? The ancillary measures in the treatment of shock is mainly the oxygen administration by mask, pain relieving drugs, sedation. When Nizami has a doubt, that is, fluid is not at all given in renal failure. No, not at all. Already I told you when we were discussing about the topic on the kidney, I told you about management of renal failure. So you have to just go through the topic renal failure. But anyway, you raised the doubt. I will just give whatever patient loses, that has to be replaced. What the patient loses? He is losing water through the skin in form of sweat. He is losing water in form of moisture through the air. So these two things are called as the insensible perspiration, that will be around 1000 ml per day. So you can give 1000 ml per day. But the normal body metabolism, if the patient is not active, he is just lying down. So at that state, the body tissues and cells, due to metabolic activity, they will produce about 500 ml of water inside. You can see the Krebs citric acid cycle. The end products will be energy, carbon dioxide, and water. So there will be 500 ml of water being generated in the body. Even the patient is not doing anything. So 500 ml is added, 1000 ml is lost. So how much balance you can give? You can give 500 ml of water. In addition to this 500 ml of water, if the patient is passing just about 100 ml of urine, you can give 100 ml of water. If the patient vomits and gets 100 ml of fluid out, you can give that 100 ml of fluid. So whatever discharges patient is having outside, that amount of fluid can be given again by mouth. So in renal failure, you have to give fluids, but that amount of fluid what you have to give in renal failure is calculated on a daily basis. What are the losses? So you add all the losses, minus it, minus 500 from it, and give that to the patient. If the patient gets high temperature, it is profuse sweating. So how long he has temperature, how long he has more than 100, more than 101, more than 103, like that, you calculate the sheets, temperature charts will be there. how much fluid will be lost. So by that you calculate the amount of fluid the patient is losing in form of sweat. So you give that water again as a replacement fluid. So that is how you give fluid in patient with renal failure. Any more doubts, please? Okay. If there are no more doubts, I will close this session and then we will have the topic again tomorrow. Tomorrow we are going to discuss about the the septic shock. Okay. Thank you. See you tomorrow.